Hey y'all, it's Lauren. Welcome back to the channel. Value-based care is not automatically or inherently equitable at all. It just isn't that way. So before I explain why and how that is, I invite you to pause and think about all the discussions that we keep having about health equity and how value-based care seems to be touted as the silver bullet. Implicit bias training seem to be how we plan on addressing health equity. But value-based care doesn't do that automatically. Okay, so first, let's talk about the difference between equality and equity. Everybody probably preaching to the choir right now, but here it is. One example of equality is that everyone gets the same thing. I like the metaphor of a pair of shoes. I have a pair of shoes. Say I'm a size 7.5. Yes, I have dainty feet. But say I'm a size 7.5 and my shoe is a rain boot. Everybody gets the same shoe, the same size of the shoe. Everyone gets that black rain boot that is a size 7.5. It doesn't matter if they're a male, if they're a female. It doesn't matter if they need to be wearing stilettos to the club. It doesn't matter if they are actually a size 14 or a size 4.5. They all get the same thing. But what ends up happening is that that's equal, the same, right? Equal means the same across the board. Now, that obviously has its limitations because, again, not everyone is a size 7.5 in shoe. Not everybody wears rain boots when it rains outside and goes splashing in puddles. Who would do that? I don't know who would do that. Not everybody is into that sort of thing. And last time I checked, if you're trying to run track, you have a different lifestyle, you're going to need a different shoe. But I apparently don't care what you need. I'm just giving you what I want to give you, which is this rain boot that is a size 7.5. Okay. So, yes, you've provided everybody with shoes. Yes, you've provided everybody with the same thing. You are equal, but it has nothing to do with the needs, the context, the circumstances, the reality of who, of the person actually wearing the shoe. So, what would be equitable would be to offer, or more equitable, not like something's equitable or it's not. Like there's a spectrum. It would be more equitable to offer everyone rain boots that were in their size. Look at that. It would be more equitable to offer everyone black shoes in their size and in the style that they needed it to support their feet if they had like diabetic feet or ran track. The most equitable, I guess, would be what we have now, which is everybody, well, not everybody has shoes, but would be everyone having the shoe that they need, likely in a color and style that suits, that's appropriate for them in their situation. So that's an example there. When it comes to value-based care is very equal. It is not equitable, which means there will always be people who miss out. There will always be people in the margins. And last time I checked, the folks in the margins don't like chilling in the margins because the system was not made for the people in the margins. Let me show you why. Imagine outcomes are on a scatter plot graph. It will naturally turn into a bell curve shape. The center of the bell curve, right, where the bell curve is highest, the center of the bell curve is what healthcare is made for and what value-based care is made for. You want volume. You want most of the patients. You want as many patients as possible. Bam. That represents the uptick of that bell curve represents volume. Okay? You want more people to have better outcomes, but that in reality doesn't go far enough. Because the truth is, and we know this in healthcare, that it's easier for some people to achieve outcomes, certain outcomes, than for other people. For example, with blood pressure, it's going to be easier for certain populations in certain communities. It's going to be easier for some people to have controlled blood pressure or to go from having uncontrolled blood pressure to controlled blood pressure than it is for other people to go from having uncontrolled blood pressure to controlled blood pressure. That's the bell curve. So if we're just like, okay, cool, the mean now have controlled blood pressure. Okay, we wash our hands, we walk away, we're done. No, not really. Well, unfortunately, that's kind of what's happening right now, but no, not really. We're not done. Because what happens is we call this a success. We're just like, great, we reached our benchmark. We got this much. We got this far. But we're calling it done and we're washing our hands and we're walking away. Meanwhile, the outlier, the outlier still has uncontrolled hypertension. And that outlier isn't just, well, first of all, those outliers represent people. But that outlier is typically the same outlier that gets left out when it comes to other value-based care, other initiatives, or anything. They might not even have internet. Oh, connectivity, yay! Bell curve. So next thing you know, they're an outlier for a number of things. They're on the margins for a number of reasons. They are consistently forgotten because we love the center of that bell curve. And when we hit the average that we want, we wash our hands and we walk away. We keep it moving to the next project. But unfortunately, again, the outlier remains there. They don't have the same experience, the same outcome, the same chances, the same access as those here. And that happens consistently. I am looking forward to being able to measure that delta or that difference between the center of that bell curve and the folks on the margins. Not only am I excited to measure that delta, because I think that that needs to be, heck, if there are scorecards out there and we're talking about health equity, to be honest with you, I think that would be a very interesting measure. Maybe we find that a strategy where we stick to the center of the bell curve consistently isn't a strategy that should be employed or deployed for certain communities. What if we built and we did initiatives specifically to identify, to measure that delta or to measure that difference, and aimed at interventions that closed that gap? Or what if we had interventions that were just for those in the margins? Just for those in the margins. Like, what if we built for those? What if we built for the hard to reach areas? And when I say hard to reach, I mean like those areas where it's harder for patients to have controlled blood pressure. Like, what if we planned according to the experience of those in the margins? What if we did that? Would it reconcile some things? I don't know. But that's an example, and that's what I mean when I say that value-based care or outcome-based care, even with what's going on with the government, which is some of the things that I actually like with the new access model coming out, I'm not gonna lie. But even with that, there are people left behind, and it's typically the same communities, the same folks over and over and over and over and over again left behind. So I just wanted to share that 2 cents about how value-based care and outcome-based care and all of that stuff doesn't automatically mean that it's an answer for health equity. In fact, it is not, unless it is intentionally built for. If you cannot measure it, at least in healthcare, if you cannot measure it, you can't address it. You can't iterate on it. So I think it would behoove us to be able to measure that distance, measure that gap, track that gap, and iterate on what we can do with technology to close that gap. All right. Have a good one. See you on the other side.
Look out for new updates.